Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session I will be discussing a very important topic in the neurology integrating with an infectious disease, that is the neurosyphilis. So if you take the general introduction or the general consideration of this topic of neurosyphilis, so the organism is Treponema pallidum. Right, so this is the organism which is responsible for the development of syphilis and even the neurosyphilis. And this neurosyphilis, it can occur at any stage of the disease. Right, it can occur at any stage of the disease. So if you take the syphilis, like we have primary, secondary and as well as the tertiary stage of the syphilis. This neurosyphilis can occur at any stage of the disease, and this particular neurosyphilis, it is a progressive disorder. Right, it is a progressive disorder and it causes life-threatening complications. Right, it causes life-threatening complications. Now, if you take the stages of this particular the neurosyphilis or like progression of the neurosyphilis, the individual will have asymptomatic phase of the neurosyphilis and it can progress up to a stage of the meningovascular syphilis. So this meningovascular syphilis, it occurs months to years after the infection, whereas the tabes dorsalis and as well as the general paresis, they occur almost 2 to 50 years after the infection. So if you take the classification or like the phases of the neurosyphilis, the individual can have an asymptomatic, neuroinvasion, number 2, meningovascular syphilis, number 3, tabes dorsalis, number 4, general paresis. Right, so these are the clinical phases of the neurosyphilis, out of which the asymptomatic neuroinvasion and as well as the meningovascular syphilis, they occur in the earlier phases or earlier stages. Right, they occur like months to years after the infection. Right, months to years after the infection, whereas tabes dorsalis and as well as the general paresis will occur 2 to 50 years after infection. Right, will occur 2 to 50 years after the infection. So that is about the tabes dorsalis and as well as the general paresis. Now first let me take up the discussion of asymptomatic neuroinvasion. So this asymptomatic neuroinvasion, this form has been reported in up to 40% of patients with early syphilis. Right, it is seen in almost up to 40% of patients with early syphilis. And in these patients with asymptomatic neuroinvasion, it is characterized by spinal fluid abnormalities. Right, there will be CSF abnormalities in these patients with asymptomatic neuroinvasion. And what will be that CSF abnormalities? That will be in the form of lymphocytic pleocytosis. So there will be increase in the lymphocyte count, and there is also occasional increase in the proteins as well. But these individuals, they don't have any symptoms. These individuals, they don't have any neurological signs as well. So there are no signs and as well as the symptoms. That is about your asymptomatic neuroinvasion, right? 40% of patients, they present this asymptomatic neuroinvasion. It is seen in up to 40% of patients with the early syphilis. Now followed by that, we have what is called meningovascular syphilis. This form is characterized by meningeal involvement, or the changes are seen within the vascular structures of the brain, or even it can be both. So either meningeal involvement or vascular structures are involved, or there is involvement of both meninges and as well as the vascular involvement. So because of the meningeal involvement, these individuals, they have the symptoms of acute or chronic meningitis. Right, symptoms of acute or chronic meningitis. And what will be that symptoms of acute or chronic meningitis? That includes headache and as well as irritability. And these individuals, they also have the cranial nerve palsies. And these cranial nerve palsy, it is seen secondary to basilar meningitis. Right, secondary to basilar meningitis, and there will be also unequal reflexes. Right, so these are the features of the meningovascular syphilis. And apart from this, there is also vascular involvement in these individuals. So whenever there is involvement of large vessels, right, whenever there is involvement of the large vessels, there is development of cerebrovascular accidents. Right, there is development of cerebrovascular accident. And apart from that, these individuals, they have poor light reflex. So they have a characteristic reflex, that is, or the characteristic pupil, that is Argyll Robertson pupil. So Argyll Robertson pupil, it is accommodation reflex is present, but light reflex is absent. Right, light reflex is absent. That is called the Argyll Robertson pupil, which is seen in patients with the neurosyphilis. And even if you take the pupils in these individuals, they have irregular pupils. So in case of meningovascular syphilis, they have the meningeal involvement and as well as the vascular structures of the brain are also affected. So because of the meningeal involvement, they have both acute or chronic meningitis, they have headache and as well as irritability. And there is also cranial nerve palsies, that is secondary to basilar meningitis, and they have unequal reflexes. And whenever there is involvement of large vessels, there is development of cerebrovascular accidents as well. These patients, they also have irregular pupils with poor light and as well as the accommodation reflex. Now, what will be the CSF picture? In patients with the meningovascular syphilis, the CSF shows lymphocytic pleocytosis. right? They have lymphocytic pleocytosis, right, where there is increase in the lymphocyte count, and even there is elevated protein, and these individuals, they also have a positive serological test for syphilis, right? So VDRL will be positive. Okay, so apart from the CSF analysis, the VDRL test also will be positive, where within the CSF, right, within the CSF. Okay, and the symptoms of acute meningitis, let me tell you, they are rare in case of the late syphilis. So we have discussed asymptomatic neuroinvasion and meningovascular syphilis, and you take the late complications of the syphilis, that is tabes dorsalis. So here in case of tabes dorsalis, what are the structures which are being affected is, there is involvement of posterior columns of the spinal cord, right, there is involvement of the posterior columns of the spinal cord, and there is also involvement of posterior sensory ganglia and nerve roots. Right, posterior sensory ganglia and nerve roots. So these are the structures which are affected in case of the tabes dorsalis, and because of the involvement of the posterior columns are the one which are concerned with the maintenance of proprioception, that is the position of the individual. It is concerned with vibration sense, it is concerned with pressure sense, it is concerned with the fine touch. So because there is degeneration of the posterior columns of the spinal cord, these individuals, they will have impairment of proprioception, right, and there is also impairment of vibration sense. And these patients with tabes dorsalis, they also have Argyll Robertson pupil, that is ARP. So what does this Argyll Robertson pupil stands for? Accommodation reflex is present and light reflex is absent. So that is what is your Argyll Robertson pupil. And the other features in these patients, they include, and because of impairment of proprioception, these individuals, they are not able to maintain the balance in the gait or whenever they walk. So they have wide based gait, right, they have wide based gait, and they also have inability to walk in the dark. Right, they also have inability to walk in the dark. So that is about the clinical feature due to impairment of the proprioception. And these individuals, if you take the tone within the muscles, there is muscular hypotonia, right, and they also have hyporeflexia, impairment of reflexes. Right, they also have hyporeflexia. So these are the features of the tabes dorsalis. And because of the involvement of the posterior sensory ganglia and as well as the nerve roots, they have the following features. They have the shooting pain across the legs, right, shooting or lightning pains, right, shooting or lightning pains may occur across the lower limbs, that is across the legs, right, and they also have paresthesias, that is abnormal sensation, right? And they also have sharp recurrent pains in the muscles. Right, sharp recurrent pain within the muscles. That is what are the features of the ABS dorsalis. And another important thing is there is also development of the Charcot joint. So Charcot joint is that where the individual has the joint damage, right? The individual has the joint damage. So joint damage may occur as a result of lack of sensory innervation, right? So this joint damage, it is due to lack of sensory innervation. Right, so that is what is your Charcot joint. Now followed by that, when you do, or if you do a CSF analysis in patients with the neurosyphilis, so the CSF either it is normal or there is increased lymphocyte count. Right, there is increased lymphocyte cell count. And even if you take the proteins, there is elevated proteins, and they have variable results of serological test, but they have normal or increased lymphocyte cell count and they have elevated proteins. So that is about the ABS dorsalis, where there is involvement of the posterior columns, sensory ganglion, that is dorsal root ganglion, and as well as nerve roots. And the another form of the neurosyphilis is the general paresis. As the word itself tells you that there is generalized involvement of the cerebral cortex. Right, generalized involvement of cerebral cortex, right? And how will be the onset of symptoms? There will be insidious onset of symptoms, right? So gradual onset of symptoms will be there. And in these individuals with the general paresis, there is usually a decrease in concentrating power. They have memory loss, they have dysarthria, that is difficulty in articulation of the speech, right? So decrease in concentrating power. They also have memory loss, they have difficulty in articulation of the speech, that is called dysarthria, and these individuals they also have tremors, right? They also have tremors of the fingers and as well as the lips. Right, they also have tremors of the fingers and lips, and these individuals they also have irritability and mild headache. Right, so these are the features of the general paresis, and most striking is the change of personality. The patient may have irresponsible, confused and psychotic behavior, right? So psychotic and confused behavior, that is what you will see in the general paresis. And if you take the CSF, it is similar to that of the ABS dorsalis. What is that? They have lymphocytic pleocytosis and there will be mildly elevated proteins, right? Now followed by that, the laboratory findings, if you see, okay, and what are the indications for a lumbar puncture? See, in early syphilis, that is in case of asymptomatic neuroinvasion, right, in early syphilis, invasion of the CNS by Treponema pallidum with CSF abnormalities occurs commonly, but clinical neurosyphilis rarely develops in patients who have received the standard therapy. So, in early syphilis, you have the CSF abnormality, but clinical neurosyphilis rarely develop. That means neurologically they are asymptomatic. So in order to pick up that asymptomatic neurosyphilis, we do this lumbar puncture. And in which phase you will have, in which stage of neurosyphilis or in which stage of syphilis you have this early syphilis, that is in case of primary and secondary syphilis. Right, that is in case of primary and secondary syphilis, and as well as in early latent syphilis, right, primary and secondary syphilis, and early latent syphilis of less than 1 year duration, you have the asymptomatic neuroinvasion of the Treponema pallidum. So, in order to pick up that asymptomatic neuroinvasion of Treponema pallidum, we need to do the lumbar puncture, right. So, unless clinical symptoms or signs of neurosyphilis or ocular involvement are present, a lumbar puncture is not routinely recommended. But yes, in order to make out whether the individual had a neurological involvement or not, you can do this lumbar puncture. Otherwise, most of the time, until neurological involvement is not there, we don't do this particular lumbar puncture. Next, another important indication is CSF evaluation is recommended. However, if neurological or ophthalmological signs and symptoms are present. So, whenever there is neurological or ophthalmic involvement is there, then you need to do this lumbar puncture. Now, what is this ophthalmic involvement? This ophthalmic involvement will be in the form of uveitis, neuroretinitis, optic neuritis, and then iritis. So, when these ophthalmic involvement is there in case of the neurosyphilis, that is another indication where you have to do the CSF analysis. And you take in case of the tertiary stage of syphilis. Right, you take in case of the tertiary stage of syphilis. See, in tertiary stage of syphilis, the individual will have iotitis. Right, there is involvement of aorta. Involvement of iritis, there will be degeneration of the optic nerve, optic atrophy, and when there can be even presence of gamma. So, in tertiary syphilis, active tertiary syphilis, you have to do the lumbar puncture in order to pick up the neurological involvement. Okay. So, most of the time, what will be the CSF analysis? Increase in the protein and as well as increase in the lymphocytes. Now, you take this VDRL, right? VDRL, it is most sensitive and preferred over, right? This is preferred over RPR, that is rapid plasma reagent test. And the serum non-treponemal titers will be reactive in most cases, right? The serum non-treponemal titers will be reactive in most of the cases. And because the CSF-VDRL may be negative in 30 to 70% of cases of neurosyphilis, a negative test does not exclude the neurosyphilis. Okay. So, in 30 to 70% of individuals, there will be false negative. Right, so even though the individual has the neurosyphilis, the VDRL is unable to pick up that particular Treponema pallidum. So negative test does not rule out negative test does not rule out neurosyphilis, right? Whereas if this VDRL is positive, that will confirm the diagnosis, right? That will confirm the diagnosis, right? So sometimes apart from this VDRL, CSF FTA-ABS, this is used sometimes. So what does this ABS stands for? That is fluorescent Treponema pallidum absorption test. Right, fluorescent Treponema pallidum absorption test, even this is being used, and this FTA-ABS test, it is highly sensitive test. Right, it is highly sensitive test but lacks specificity. That is about the importance of this fluorescent Treponema pallidum absorption test, right? So that is about the VDRL and as well as the other important serological test, that is FTA absorption test. Now, how do you treat this neurosyphilis? Neurosyphilis, it is treated with high doses of aqueous penicillin. Right, treated with high doses of aqueous penicillin, and this aqueous penicillin, it will achieve better penetration and higher drug levels within the CSF. So this will cross the blood-brain barrier and it will achieve the higher drug levels. Right, so that is about the treatment, that is aqueous penicillin. Right, and what about the benzathine penicillin? See, benzathine penicillin G, even it crosses the blood-brain barrier, but this aqueous penicillin, it has better penetrating capacity than compared to that of benzathine penicillin. And what about ceftriaxone? See, there is limited data for using ceftriaxone to treat the neurosyphilis, right? But because other regimens have not been adequately studied, patients with history of IgE mediated reaction to penicillin may require skin test for allergy to penicillin, right? So in those individuals who are allergic to penicillin, we give this particular ceftriaxone, but there is limited data for using this particular ceftriaxone, right? And the aqueous penicillin, you have to give nearly around 10 to 14 days. Right, you have to give 10 to 14 days, but the CDC recommends even 21 days of the aqueous penicillin is also being used. And all patients treated for neurosyphilis, right, all patients treated for neurosyphilis should have a non-treponemal serological test done every 3 to 6 months. So every 3 to 6 months, all patients whoever have been treated with the neurosyphilis should have a non-treponemal serological test right? Non-treponemal serological tests have to be done every 3 to 6 months. And CDC guidelines recommend spinal fluid examination at 6 months interval until the CSF counts have become normal. So the CDC, it recommends you have to do a CSF analysis, right? You have to do CSF analysis every 6 months until the CSF cell count is normal, right? Until the CSF cell count is normal. Okay, so that is according to the CDC guidelines. And for suppose if the serum non-treponemal titers do not normalize, then you need to consider repeating the CSF analysis. Then you have to give a second course of the penicillin therapy. That is about the treatment of the neurosyphilis. So neurosyphilis, we have 4 forms: asymptomatic neuroinvasion, then we have meningovascular syphilis, tabes dorsalis, and then general paresis, right? So mainly later ones like tabes dorsalis, general paresis, right, they are more harmful to the patients than compared to that of your asymptomatic neuroinvasion. But picking up this in early stages and treating with adequate doses of penicillin is very important in the treatment of neurosyphilis. So this completes the discussion of this topic of neurosyphilis. Thank you very much.